Good morning, everyone. I'm Jeff Brown, and this is a program of First Parish Church of Stowe and Acton. If you've got a question for Ingrid, please put it in the chat box. And I'm going to welcome Ingrid. Are you there, Ingrid?
Hear me?
Yes, I can.
Thank you so much for having me.
You're welcome. So I'm going to spotlight your, see if I can do this. Okay, there we go. So originally, I was going to have Ingrid come on last summer, but it seemed like the experiences were a little bit too fresh, so I didn't pursue that. And then I asked her to come in February, and then you had a second wave, so you weren't unable to do that. And then we thought we'd schedule it for May and last month, and that turned out to be your wedding day. So congratulations. I see you have a new last name.
I do.
That's good. Hope that went well.
It did. Thank you.
And then, so here we are today. And that's great to do this. So I wanted to start, well, actually I want to start with, behind your name, you've got the initials DNP, FNP-C, AGA, CNP-BC. So what the heck does all that mean?
I mean, us nurses, we have way too many letters at the end of our name to seem really important and confuse everyone. But essentially the DNP is just my highest degree, which is a Doctor of Nursing Practice. And then the FNP and ACNP are just the two specialties of nurse practitioner that I'm board certified in. So one is in family medicine and the other is in acute care, which is what I practice in now in the medical ICU here at NYU Medical Center.
Okay, good. So I want to start by tracing two paths that you've taken, one towards nursing and one towards New York City. And see how you got to be where you are. So you grew up in Acton on Henley Road, which I am at right now. All the old members of Henley Road have moved away, including your parents. And you went to AB High School.
Mm-hmm.
And when did you first think you wanted to be a nurse? Did that start in high school?
No, it didn't. Honestly, I was pretty focused on basketball through high school, to be quite honest. I didn't really think of a career choice at that time. And then I had a series of injuries back to back. So ultimately was not able to really play past college, so had to figure something out. And with those injuries, I had some really nice experiences in the healthcare system. And decided on nursing to pursue that. And ultimately, you know, by the end of my bachelor's degree, really loved the profession. I originally worked as an emergency department nurse down at Duke Medical Center, and quickly went back to school there to pursue a master's degree to become a nurse practitioner.
So
I had some really great mentors that sort of led me from nursing to become a nurse practitioner at the time and wanted to practice more independently. So that's sort of what led that path. And now actually the vast majority of my practice is teaching. So after I got my doctorate, I now teach NP school and doctoral level nursing at PACE and NYU. So that's sort of been my path with nursing. It has been such a great profession. I really enjoy every single day I go to work, so I could not be happier with the choice I made.
That's good. So where did you go to college originally?
So I went to UMass Dartmouth for my undergraduate, and then went to Duke for both my master's degrees and my doctorate.
Okay. So, all right, well, that's your path to nursing. What about New York City? Why did you go there?
Well, after I was finishing up schooling at Duke, I really loved it as a hospital system, but I missed the Northeast. So I knew I wanted to come back up here. So, you know, I have family in Connecticut and in the Boston area. So I was looking at job openings in both of those cities, and ended up just really liking my interview at NYU. So I decided to come here, be closer proximity to my parents as well.
So when doctors get started, they have a residency, and it seems to me that they don't have a choice of where to go, but you obviously did. You could apply to places and then
Yeah, so it's a little bit different as a nurse practitioner. You do your clinical component of your training during your degree. So once you finish, you're already board certified and ready to practice. So I didn't have a residency I had to match to. This was just my first job after, you know, completing my training.
Okay.
Mm-hmm.
So the last question before we get into COVID is, what was your week like pre-COVID?
Pre-COVID. So interestingly, it's sort of the week that it hit is the one that I can remember most because my birthday is in March.
No.
So I remember like trying to sort of decide whether I wanted to do something for my birthday, and then everything sort of shut down. It was very abrupt. You know, we sort of heard even back in January some inklings of COVID and what's it going to be like. I think we set aside like 2 rooms in our ICU for potential COVID patients, which looking back is, you know, definitely not prepared for what was to come. But there wasn't too much concern until it was here and everything sort of shut down. So it was a pretty normal week until it wasn't, to be quite honest.
How many hours of nursing do you do, and how many hours of teaching were you doing pre-COVID?
So at that point, I wasn't teaching full time yet. So I was doing about 40 hours of work at the hospital, plus maybe an overtime shift here or there. So somewhere between 40 and 50 hours a week.
Okay. Now I am going to try to share my screen. See if I can do this. Okay, can you see that? Is there a map of Manhattan in front of you?
I can't.
Okay, well, hold on one. Oh, I know why.
Maybe because we're in the spotlight mode.
Well, I know I didn't share my screen. Okay.
Oh, there you go.
Can you see that? Okay.
Yes.
So, okay, so I'm not too familiar with Manhattan, but where do you live? What section, and where do you work?
So I don't live in Manhattan. I live in Queens, which is right across the river there.
Okay, yeah, see it right
Yep,
there?
exactly. And I work in Murray Hill, which is down right below Midtown East.
Right there.
That's where NYU Medical Center is, and also Bellevue, which is the main city hospital in Manhattan, are both in Murray Hill.
Okay. Now, just as a review, here are the kind of the big points of, you know, the COVID thing. China reports its first COVID death in January, first case on the 21st, first death the 29th, March 1st, the first case in New York State. Cuomo orders containment zone in New Rochelle, and events over 500 people have to be postponed. And the 12th of March, Trump declares national emergency, first deaths in New York State. Uh, New York City has a pause program where all non-essential workers have to stay home. New York City passes 1,000 deaths. And then to May, US deaths pass 100,000. So that's just a review of what we went through. Seems like such a long time ago. So you said you first heard of COVID, had inklings of it back in January?
Yeah, there started to be a little bit of buzz around the hospital, and some start of some potential planning. Nowhere near the magnitude we actually saw it. Did we think it was going to happen? Like I said, I think we had 2 isolation rooms in our medical ICU that we were sort of holding in case we had patients with COVID. Probably sometime in February is when that sort of rolled out. But I would say the vast majority of staff here were not so concerned about it, to be honest with you. I remember there was one attending physician in particular that was like, this is going to be big. This is going to be way worse than we think. But overall, as far as administration and staff overall, we weren't so concerned in January and February.
How do you get your information? I mean, how does it come down the pipeline?
Sure. So it comes from, the higher ups go to our middle management. So for us here in the ICU, there is a medical director of the ICU, which is an ICU physician here. So she disseminates a lot of the information to our ICU doctors and advanced practice providers, as well as on the nursing side. So the nursing management also disseminates information from that side as well.
So by March 1st, it was confirmed that the first COVID case. So do you remember, did you have any ramping up at that time?
I still don't think there was much in the hospital. I remember I was getting concerned because my now in-laws live in New Rochelle, which is where, there was the first sort of outbreak there. As that first patient, I actually remember because that patient was taken care of at Columbia, which the medical community is very small. We know each other, in critical care at many hospitals. So we are starting to get a trickle down of how sick this patient was and how much support and intensive care that they were requiring, which is very surprising. But I still don't think anyone in the hospital was expecting to see that many cases. We were just like, oh, if we get them, they may be very sick at that point.
So was that first patient, was he or she in isolation?
Yes, at Columbia. I mean, I can't say for sure because it was at a different medical institution, but yes.
So your hospital, any hospital, must have a supply of PPE, right? Mm-hmm. Masks, and is face shields a normal part of that inventory?
Not normally. So the type of masks that we wear for these patients are the same masks we wear if we're concerned about something like tuberculosis. So we've always had that type of mask on hand. There's a couple other bacterial infections that require it. As far as the face shields, that's something we more reserved for procedures we do here in the ICU, like putting breathing tubes in and other procedures that we do. We would use face shields, but not just on a daily basis walking around.
And what else was in that PPE package? You have overalls?
We have gowns, gloves. There were sort of bonnets to cover your head. There were little coverings for your shoes sometimes.
Right. And do you remember when you started to at least be concerned about your supply of PPE, or when you ran out?
Honestly, our hospital did a pretty great job. There was maybe 1 or 2 days that I had trouble finding things the entire pandemic. So at NYU, we didn't have a huge problem with PPE. So we were very, very lucky. Well into the pandemic, into maybe April, there was like one day where we were very short on gowns. But overall, our hospital did a great job of keeping us supplied. So from that standpoint, I never felt in danger.
Yeah, I heard some report on the radio, I think probably in February or March, that this supposed expert said we're going to need 3.5 billion masks.
Yeah.
And I don't want to make any political statements, but was there any talk that the government should have been forcing companies to manufacture more things?
Oh, of course, especially when we heard about colleagues, especially we are not in a city hospital. You know, we are in a hospital that has a good amount of income. So I was very lucky, but we have colleagues that were in the city hospitals that were very short on PPE, some that didn't have gowns. And on top of that, running out of supplies for patients. So certainly those kind of things, we were definitely hoping that the government would step in and help us. But I felt certainly very early on that there was definitely a downplay to what was going on here. You know, seeing these videos of people not believing what it was like, that we were lying about what was going on. I saw that all over the news all the time. So actually, before, you know, stating to make something, you have to acknowledge that it's happening. And I didn't feel like overall that was sort of the sense that I was seeing.
Yeah. And what about ventilators? I know Cuomo wanted, I believe, 40,000 ventilators. How was your supply of them?
It was good. We had to be creative. At the peak point of the first wave, we had over 200 patients on ventilators. To give you some comparison, right now in our medical ICU, we maybe have, I don't know, anywhere from 10 to 15 people on ventilators, which is sort of the norm. So to have now over 200 on ventilators was astronomical. We brought up ventilators from the operating rooms. So we brought those up for use. We converted some ventilator type machines that we usually use with masks to be able to use that with a ventilator, but we actually never ran out. And further down in the course, we did get another shipment of old ventilators that we refurbished from some company. And I believe that was government funded at that time. But we never ran out of ventilators here either.
That's good. But do you think that other hospitals in the state did?
For sure. Absolutely. There were hospitals in the state that ran out of wall oxygen. So just the oxygen that you would put in the nose. So something as simple as that, patients were out of in some of the ERs in New York City.
Yeah, that sounds like that's the problem in India now, that they don't have any oxygen or not enough.
Mm-hmm.
Yeah. When did your hospital reach capacity? When was the worst of it?
Probably sometime in April.
Mm-hmm.
I don't know exactly when, but the hardest part to really deal with it was in March because the curve was so steep. So in any given shift, I was putting breathing tubes in 8 to 10 patients in one shift. So the amount we usually have on a ventilator overall, we were, you know, doing every shift for a week or two, where it just never stopped. It was like a continuous flow of these patients. So I would say the hardest working portion was in the end of March, first week of April. And by the end of April, we probably reached our peak of at least intensive care patients.
Right. And were you working extra hours at this point?
Oh, yeah. I was working almost 7 days a week.
Oh, boy.
We basically would come in as much as we possibly could. And, you know, our colleagues would kind of check us like, you need a break, maybe you should take a day off. But being at home, knowing what your colleagues were going to, you'd just go crazy. You'd sit there and feel so bad, knowing sort of the devastation that they were seeing and how short-staffed we were for the amount of patients. So it almost just felt better to be here.
Did any of your colleagues get sick?
Mm-hmm. Yeah. We had probably 3 or 4 people of the ICU doctors and nurse practitioners get sick. None of them were hospitalized. They just felt pretty crummy at home. But we did have employees in the health system that got sick and were, treated in intensive care, and some that passed away. I would say maybe there was probably 8 employees from our hospital that were sick enough to be hospitalized during the first wave.
Wow. So earlier you said you really enjoy nursing, and you like to go to work every day. But at the worst of it, when you woke up in the morning, what was your first thought?
There was honestly not much time to think about it. In the worst of it, everything was just on adrenaline. I don't think many of us were processing what we were seeing. You just sort of did what you have to do and moved on to the next patient. And there wasn't any time to sort of take in what you were seeing or feeling. And you were just so tired from working so much. There wasn't much emotional processing, I would say, at the height of it.
Right. Now, you said you had to commute from Queens to work. So how did you do that? Did you drive or take the mass transit?
Sometimes I would take the mass transit. I would be like the only person in the subway car going to work at that time. As it got later on, I often took cabs because I was just so tired from working so much. I couldn't get up the extra hour early to get to work. So that's sort of an expense that I took on later on just from the amount of hours I was putting in.
When you were traveling around in those days, how were you dressed? Were you dressed in hospital garb?
Yes.
So people would know you were a medical worker.
Mm-hmm.
And did you see other people that should have been wearing masks but weren't wearing masks, or was it pretty widespread?
It was widespread. I would say New York, from what I've seen, has been very good with this.
Oh, good.
Mm-hmm.
Did you ever? I've heard of the banging of pans and so everything at 7:00. Did you see any of that?
Yeah, our fire department would come outside at change of shift and run their sirens. And people would come out, especially in the earlier times, of their windows and bang pans. Even in Queens, at 7:00 on a day it wasn't working, I would hear, cheers and banging of pans, which was very uplifting and very nice to see. Yeah. But it faded off quite early, even though the work continued on.
Yeah, I'm sure. Now, you were living with your fiance?
Mm-hmm. Yeah.
So did he have to go to work?
The unfortunate timing, he's an attorney. In January of that year, he left corporate law to start his own law firm, which, if you can imagine, the beginning of a pandemic is not an ideal time to start a business. So that was very difficult because he was home. Work was very, very slow. So he had to be home essentially worrying about me most days. It was a very difficult time for him, maybe more difficult for him than I.
So how did it work that you'd come home and well, I've just heard stories that you strip off your outer clothes and put them in the wash. Man, was there any concern that you'd pass the COVID to him?
Oh, absolutely.
Yeah, of course there was concern, but when I got in, I literally had this like little decontamination station right at the door. I had bleach wipes. I would like bleach my shoes. Everything would come off and go right into a bag that would stay right there. And I'd go right into the shower. I had alcohol wipe anything I had with me, cell phone, ring, glasses, anything to try to reduce that risk.
Yeah. And did you see your parents?
I did not. Definitely not.
Wow.
Not for a long time.
Yeah. So it started winding down, the end of last year?
I mean, the craziness of the surge, yes, because there wasn't as many patients, and we understood the disease a little bit better. But up until maybe last month, 100% of almost 100% of the patients I was taking care of were respiratory failure from COVID.
Wow, geez. And then you said you had another wave. Well, how many waves did you have? I know you had one in February.
Yeah, there were two large waves. So there is the first one, and then the summer sort of got a little bit better, and then it had an uptick again back in the fall.
Mm-hmm. And how is it right now?
For the first time, I think I only have 2 COVID patients out of 10 I'm taking care of today.
Wow,
So
that's good. And we expect that to go down to 0, hopefully.
I hope so. Some of these people have been here for like 3 months, so it's not a new infection. They're just still critically ill.
Oh, so some of your patients are what they call long haulers?
Mm-hmm.
And what's the definition of that? How long do you have to be to just over?
I mean, after about a month, I start to think of them that way. I don't know if there is an exact definition, but we do a special therapy here called ECMO, extracorporeal membrane oxygenation. I don't know if anyone has heard of it. It's been on the news, where essentially it's a step above a ventilator, where we put someone basically on lung bypass. So we take out their blood, it runs through a machine, we put oxygen in it, we remove carbon dioxide, and then we put the blood back in. So the machine essentially takes the job of the lungs. And with that, we're able to keep people alive who would otherwise die on a regular ventilator. So some of these people are on this machine for 2, 3, 4 months.
Did you experiment with any of the therapeutics that were on the news?
I mean, we have used many. It has been quickly changing over the course of time. The ones that we typically use are steroids. We've seen actually trials that show effect of that, and something called remdesivir, which is an antiviral medication. There's some others that have some pretty poor studies behind them, but in our critically ill patients, nothing much else works. We are doing a trial now for convalescent plasma, so we enroll patients for that trial, but anecdotally, I have not seen it work.
So the remdesivir, did that have studies behind it?
Mm-hmm.
It did. And that was
well, it has not when we started using it, but it has now.
Yeah. Mm-hmm. Okay. That's good. And how did the vaccinations work out? How did that get started, and is it in good shape now?
Yeah, so we started getting vaccines in December. As healthcare workers here at NYU is very accessible, very easy to get. I think over 70% of New York State is now vaccinated, which is pretty good as compared to other states in the country. And hopefully this number continues to rise. There are very few patients that come in critically ill that were vaccinated. So that seems to keep you out of the ICU. I've maybe seen 1 or 2 that have a very weird variant of COVID from another country who have gotten sick. But for the most part, people who come in here and need a ventilator were not vaccinated. So it certainly appears to work.
What do you think about all the variants, but specifically the Delta variant?
Yeah, that's the one that I've seen that people have gotten ill despite vaccination, but I have not seen many patients with that, and it's not something we routinely tested for in these patients, so it's unclear the vast majority of patients with COVID what variant they have. Only in very specialized cases that don't seem to add up, like maybe they got the vaccine, do we send out for testing of the variant.
So you're saying that you've seen cases where the patient's been vaccinated, but has caught COVID through the Delta?
Yeah, maybe 2.
And
keep in mind, I also do time at Bellevue Hospital, so it's a large number of patients that I'm seeing that I've seen this twice. Yeah. So it's very uncommon.
I mean, they do say that the vaccination, 95% effective, right? So that 5% leaves the door open for either whatever COVID strain, right? And is it true that the Delta is much more contagious?
I have not seen the studies on that, so I can't comment medically that that's the case. But the preliminary reports, it seems to be that that is what's happening.
No, we get all in the news that there are studies. We'll get results of studies all the time. So in the medical field, I mean, who is doing these studies?
Everyone, and honestly, you know, you can't believe every study you hear. When we read a study, we dissect it for how well it was done. There's many things that we look at, and you know, not even just with COVID, with anything, you know, many things I read at the end of it, I'm like, well, that's a poor study. I can't really conclude much out of that. Even though they say their results are this, maybe it wasn't set up well. Without getting too scientific, that's kind of the short answer of that. Is we are very critical of the studies that come out and how they were done, and how many people were in them, you know, that sort of thing.
Is there some kind of, I don't know, magazine or organization that kind of vets these studies? And
many of them. So to be published, different journals have to vet them. But journals publish not the greatest studies all the time. So I would say the quality of the journal certainly would make me, you know, read something more carefully. So things like the New England Journal of Medicine, big time journals that really vet their articles beforehand.
Yeah, good. Okay, well, if anybody has any questions, again, write them in the chat box. So do you think in general that New York State did a fairly good job of handling the COVID or not?
Before it hit, no. I wish we would have been way more prepared as a state, city, and country. But, you know, once it did, it was really all hands on deck. You know, the amount of work put in by all the people who work in the hospital, not just the healthcare workers, but the security guards, the people who answer the phones, the people who deliver the meals, who clean the floors. Everyone was amazing. Local businesses provided almost every meal I ate in the hospital for the first like 6 weeks. So there was always something to eat. We didn't have to worry about that. You know, overall, we really just came together as a city and made do with what we had. So I would say, you know, once it was here, we did the best we could, and it was pretty impressive, at least I can say, for what we did at our hospital, you know, and the amount of lives that we saved that would otherwise not have survived this illness.
No, that's great. I don't know what we would have done without nurses like you and doctors and so forth. I do have a question from Rick. Is there any information on the survival rate of patients once they have been put on a ventilator?
It's very hospital dependent, and it has changed over time. As you can imagine, in the first wave, when we had 200 patients versus now when there's not as many, you know, there's a little bit of difference. Our hospital, you know, over 50% of people who were put on ventilators ended up surviving and leaving the hospital, but that's actually quite good. There were hospitals in New York City where it was less than 10% in the first wave.
That's.
But once you're put on a ventilator, you're very sick, and I would say, you know, for most people, it's about 50-50.
Mm-hmm.
It's also very, very hard to predict who's going to do well and who's going to do poorly. There's certainly some patients who normally don't do so well, unfortunately, like patients who don't have immune systems because they've had transplants and such. But otherwise, we've had young, otherwise healthy people, unfortunately, get very sick.
Yeah, and there's no indicator as to who would get sick and who wouldn't.
Yeah, for the most part. I mean, we know people who are obese don't do as well once they're critically ill, and have a higher risk of needing a ventilator. But other than that, it's very hard to predict when people are infected with the virus who are going to progress to the point who need a ventilator and who will have no symptoms at all.
And the elderly is just because their systems aren't nearly as viable as younger people.
Yeah, well, even without COVID, if you're elderly and put on a ventilator, your chance of not surviving is much higher. Your body just cannot cope with the stress of illness. You often have other organs other than the lungs that aren't working properly in those cases. So certainly any elderly person who's sick enough to be put on a ventilator, regardless of the cause, has a higher mortality.
Okay, so you talked, I asked you in the beginning of this program what your week was like. So what is it like now? Are you're teaching a lot more?
Yeah, so I finished my doctorate in the summer last year, and I started teaching full time at that point. So I teach, about 12 to 14 graduate credits a semester. So that's like 3 or 4 classes. And then I come to the hospital 6 days a month, which is about half of what my colleagues do. And life definitely feels more normal in New York City at this point. People are out most of the time still wearing masks, even though that restriction has been lifted, at least outdoors. People are vaccinated. There's some semblance of normal life again.
That's great. So was the theory that New York City got it so bad just because there's so much international travel?
I think that, and just the close proximity of which everyone lives here, and how everyone travels, you would have a train car with 50 people in it. And if one person had it, that's a very fast spreading event. You go to every borough, you go outside of New York City with that. So I think probably public transit, close proximity of where people live, just number of people, as well as the international travel.
And you're at the hospital right now, is that right?
Yes, I am.
Okay. There's another question. Have you encountered any vaccine hesitant people who refuse the vaccine?
Yes, many. And it's very frustrating. I understand where they're coming from, and many times it's a knowledge deficit, that they're concerned about the safety of the vaccine. Certainly, there is mistrust in medicine in many populations, rightfully so, in this country. So that also plays a role in it. But to see the devastation that I've seen and know that there is something to help prevent it, it's very frustrating when I encounter that. So I try to just educate people as much as I can about the benefits of the vaccine. And that's sort of all we can do.
Yeah. Okay, so in the last few minutes, I know you have to go and do your job pretty soon. So you're a nursing professor.
Mm-hmm.
Now, what do you think the most important things that you can tell your nurses, or start with that.
About COVID or
No,
in
not
general?
about COVID, just about being a nurse.
I would say, obviously teaching the science behind nursing and how to do your job medically. But I think one thing that is really lacking in our education that has really come to light is self-care and how to take care of yourself. Seeing everything you see and dealing with everything you deal with I mean, in the height, it would not be abnormal for me to personally pronounce 3 people dead in a shift. To be the only one in there holding their hand as they died because their loved ones were not allowed in, and then to have to make these phone calls to families every day, calling 20 families and tell them that their loved one could die today. It's very emotionally taxing, and I don't think we're taught enough how to process this information and to care for ourselves in a way that we can take this, cope with it, and continue to do our job. So I try to take some time in class, as many of my students are practicing nurses already, just to talk about and debrief on what they've seen and how they're handling it, and sort of foster open communication, because many times we don't speak about this portion of the job.
Well, that sounds great. I've got one last question. What is your level of concern about another outbreak from another source?
Certainly, I'll always be concerned, especially after, what I've seen in the last 2 years. But at this time, I haven't really seen anything in the hospital yet, so nothing that's sort of alerting me that something's to come. But I think it will be a long time before I can sit back and not be on my toes about something like that. And same for hospital systems. I think that for many years to come, they'll be ready and prepared for the worst possible outcome.
Good. That's great. Well, I want to thank you, Ingrid, for both coming today and for what you do, and that you're training more nurses coming down the pipeline.
Of course, you're very welcome. Thank you for having me. It's so nice to see you. I wish it could be in person. I miss Henley Road.
Yeah, I bet you do. We miss you. Okay, well, take care.
All right. Thank you, everyone.
Okay, bye-bye.